Hi, good evening, good afternoon, good morning, everybody. Wherever you are, I'd like to welcome you all to this new Journal Club broadcast by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And today, our journal club is dedicated to a paper recently published in the Lancet Hematology in the field of multiple myeloma. As usual, I'd like to thank all our sponsors for the unrestricted educational grants. And here you can see this paper recently published, which is about the addition of isatuximab to lenalidomide, bortezomib, dexamethasone as induction therapy for newly diagnosed transplantation-eligible patient with multiple myeloma. This is a GMMG HD7 trial. And these are the results of part 1 of an open label, multi-center, randomized, active controlled phase 3 trial. And to discuss this very important trial, we have two distinguished panelists today, namely Dr. Elias May, as you can see, who is co-first author of this lovely paper. Congratulations, Elias. And also another expert in the field, Dr. Bruno Paiva from Salamanca. Dr. May is from the University Hospital of Heidelberg. Here you can see the abstract and summary of this trial. And I don't need to spend a lot of time to explain to this audience that induction therapy is a key component before autotransplant in myeloma. And we believe, and I think trials are in line with this, that autotransplant is and remains the standard of care for the time being in multiple myeloma. And we have, I think, already at least two important trials, namely the Cassiopeia trial, but also the Griffin trial, which are randomized trials, one phase 3, one phase 2, which have established the value of adding an anti-CD38 monoclonal antibody to a classical triplet regimen with bortezomib and IMiD and dexamethasone. And here, the specificity of this trial is that the authors used another monoclonal antibody, another anti-CD38 monoclonal antibody, namely isatuximab, which is, by the way, already approved in multiple myeloma in the relapse setting, either in combination with pomalidomide and dexamethasone. This is based on the famous IACH trial, and more recently in combination with carfilzomib and dexamethasone. And again, this is the IACH trial. And here, the authors used in this phase 3 randomized trial, it's an academic trial, 67 academic centers, aged between 80 to 70. So it goes now beyond the famous threshold of age 65 in the transplant setting. And patient received VRD plus isatuximab. And what is really unique, I think, in this trial is that the primary endpoint, in contrast to the other trials testing quadruplet induction, was the achievement of MRD negativity using a flow cytometry. And to make a long story short, the investigators could show the superiority of a quadruplet regimen, and most importantly, they could show a very impressive rate of MRD negativity, roughly 50% in the isatuximab group versus the control group. And this is about a hazard ratio of 1.82. And some very senior colleagues in the field would remember that historically with the vincristine adriamycin dexamethasone induction we used 25 years ago, we were achieving less than 5% of complete remission, exactly 4%. And now we're talking about 50% MRD negativity after induction. You can see these results summarized on this table. This is table 2 from the paper. Of course, the authors looked into response rates based on the IMW criteria. Another interesting finding is when looking to the different subgroups, and we will discuss this in a few minutes, actually it looks like that the results are in general always in favor of the isatuximab-based induction regimen prior to auto. And you can see the editors in the journal have nicely summarized the added value of this study, which is now in a randomized phase 3 academic setting, is establishing the value of a quadruplet induction, but also with the use of another anti-CD38, because the other trials, Cassiope and Griffin, used daratumumab, and this trial is using isatuximab. And the other important point, in my opinion, is about, for the first time, using MRD as a primary endpoint. When I say for the first time, there are other ongoing trials using MRD as a primary endpoint, but here we have already the results. So with this, I'd like to welcome our two panelists, and I would like to thank you all for joining us, for being loyal to the Journal Club. I know it's a very busy week because many of you are now packing and getting ready to travel to New Orleans to the American Society of Hematology annual meeting. So by the way, don't forget your passport, your ESTA. If you didn't apply for one, it can take a few hours or up to 48 hours. So, and of course, please don't forget the founding principle of the Journal Club is that it's an interactive activity. So please send us your questions and comments. So after my summary, always the first question goes to the panelist who did not participate, who is not a co-author of the paper. And this is here, Dr. Bruno Paiva. So Bruno, when you saw this paper, and I guess you were not very surprised because we heard the data in an oral session previously, what was your reaction? Was it a wow effect, or was it, well, you were a little bit worried? Can you give us your feeling and your first thoughts about these results, about this trial?
Absolutely. Thank you, Mohammed, for another invitation to participate in the Journal Club of the International Academy for Clinical Hematology. It is a great pleasure to participate in this particular journal club because, as you emphasized, the primary endpoint was MRD negative rate, and MRD is something very close to my heart. I'm obviously not a co-author, but I think I can say that I'm a very good collaborator of many of the authors, and therefore it's again a pleasure to spend the next hour in the company of Elias. First, I would like to congratulate Elias and the whole team for a solid study. That was my reaction. This is a solid study, well reported, well executed. And I would also like to congratulate the authors for being brave by establishing an endpoint, a primary endpoint that is different from normal, not PFS, and MRD negative rates, which is also different from other primary endpoints in similar trials such as stringent CR. So I think that it was a bold decision. I think it paid off, and you may be paving the way for subsequent clinical trials that will suffer, in a way of speaking, will suffer from the same positive results you are describing here. And allow me 2 minutes to elaborate on this thought. The backbone is already the combination of proteasome inhibition together with cereblon degradation, and on top the glucocorticoid, and we know this is very synergistic. We don't understand fully why, but we know it is very synergistic. But I should emphasize that proteasome inhibition leads to immunogenic cell death, and cereblon degradation leads to T and NK cell activation. And in my opinion, this is very important because you are adding on top of the 3-drug regimen that is a standard in myeloma, an anti-CD38 that, in addition to direct apoptosis, triggers complement-dependent cytotoxicity, ADCC, as well as ADCP phagocytosis. So I think that these 4 drugs is like a dream team of drugs for an induction regimen. And as Mohammed reminded us at the beginning, the study was conducted in transplant-eligible patients. So we are looking into a very highly synergistic combination in a patient population that itself has a very long PFS. And in fact, despite the differences, it's not my area, but in the duration of induction, 18 weeks in the German study, 24 weeks in the Spanish study, you achieved in the control arm more or less the same MRD negative rates we achieved with VRD induction, 6 cycles, which is around 34-35% at a 10 to the -5. And
so
Dr.
that gives
Blade,
you confidence in the reliability of the results.
Absolutely, and the same method. And Dr. Blade reported in the plenary session of the International Myeloma Society meeting that the median PFS at the Spanish 2012 study was 80 months. 80 months. In my opinion, this justifies your braveness of introducing MRD as a surrogate endpoint, because otherwise the readout of your study you need to wait 5-6 years in order to achieve that. Finally, and this is my final introductory comment, the delta in MRD negative rates between the experimental and the control arm was 14%. And to put into context, it was at 20% after consolidation in the Griffin study and 15% after induction in Cassiopeia, meaning that most likely this delta will be clinically meaningful.
Thank you very much, Bruno, for this in-depth analysis, but also your kind words for Elias. So I think we are really in the best setting to discuss this trial, because apparently there is a consensus about its importance. So my question to you, Elias, and I think Bruno used the word, you were brave to decide on testing MRD negativity as a primary endpoint, because when I look closely to the paper, the first patient was included in October 2018. So my best guess is that it took you roughly 2 years to prepare such trial. This is usually what's quite common. So that means around 2016 and 17, while I think very few people would have dared to use MRD as a primary endpoint, actually you decided to do it. So can you just explain to our audience the context and the rationale when, not today, because today it may look obvious, but 5 years ago, about this decision and why?
Yeah. Yeah, so thank you, Mohammed. And first of all, I want to thank you for the invitation. It's really a pleasure and an honor when I see this large audience to be here and to discuss with you and also my dear colleague, Bruno, the results of our trial. And I want to thank you, Bruno, for the very kind words and introduction. And it really gives me a good feeling that at that time, 2017 or end of 2016, when we started the trial, I agree when I see your words now that it was a kind of a brave decision. So the reason we got there is I have to elaborate a little bit for you the background. So basically, in the German landscape, it's sometimes not so easy to conduct trials. But once you have the centers, they can really strongly recruit patients. And when I started in the German speaking myeloma group, it was at a time when the GMMG MM5 trial, so 2 generations earlier, was ready for readout. And I was actually the lucky physician who got to work on the readout of that trial. And already there, we decided to split the trial because it's so difficult to start such a large trial with 2 endpoints. And already in the MM5 trial, we had an early readout of non-inferiority regarding VGPR rates, comparing the PAD, which was at that time the broad standard in Germany, compared to the VCD, which is, I think, still a good standard that can be used if you use a triplet. And we could demonstrate non-inferiority. And the second primary endpoint of this MM5 trial was then comparing PFS between 4 different treatment strategies. So in HD7, we decided to go for the same way because we wanted to have a quick readout. And then we said, okay, our treatment will be very long lasting and we will give maintenance for up to 3 years in transplant eligible patients, which are aged 70 years or higher. And now we know, and we didn't know it in 2016, but now we know that with the long-term readout from the determination trial, that we have with only 3 cycles of RVD transplant and then lenalidomide maintenance, we have a median PFS of 68 months. So this was already a very long time, but we didn't know that. So we said, okay, what are we going to do? And at that time, there were a lot of papers, and I really have to emphasize Bruno's role there, because MRD measurement via flow cytometry was standardized at that time. So for us in Germany, it was a technique we could establish based on the Euroflow panel. And we saw from our own experiments in Heidelberg that it was very reliable, very safe, and that we could have a very, very quick readout. And this is something I wanna emphasize here, that within 48 hours, I can give you a report if your patient is MRD negative by flow or not. And it's a very reliable technique. So you can send samples from across Germany, and we showed that this works with 67 centers, and some of these centers only included 2 or 3 patients. And I can tell you, we see no major deviation between the centers. So it's not like the small centers MRD didn't work or something like that. We had a very, very low dropout. You don't need a baseline. That was one big thing. Of course, we did a baseline for all the patients, but you don't necessarily need it to get a flow readout at the end of induction. And then we went on and thought about the next steps. So we said, okay, we're going to do MRD negativity. And at that time, we were into some discussions indirectly with the FDA and the EMA, and they said, okay, if the PFS will prolong so much in myeloma patients, so a broad majority of patients can have a very, very long first progression-free survival, which is half the battle in myeloma, we're going to go for MRD because we believe it will be approved in 2021 or 2020. Now we know that it's such a high hurdle and we didn't take it yet. And I think this is for the disadvantage of our patients that we didn't take that hurdle yet, because I think MRD, as Bruno mentioned, and within all the single trials, if you see a significant or important MRD difference, it always translates into progression-free survival benefits. So basically the data was already there in 2017. that we saw in the single trials. It always separates. So that was then the idea.
We'll talk about the technique, but maybe Elias also, I think, and again, I'm trying to put this in context, in the historical context. You chose also a different anti-CD38, isatuximab. And I know it's a big debate, you know, the difference between the different monoclonal antibodies, but simply I'd like to highlight that although the target is the same, but the mechanism of action of these antibodies can be different, and this maybe also can translate into clinical impact, although we don't have yet the final evidence for this. We need to be balanced. What do you think?
Bruno, you want to start?
well, the antibodies are certainly different. The origin, how they are generated, the epitope they bind, and I think that there are some nuances about what can be triggered, what can not be triggered. For example, direct apoptosis in one, CDC in the other. But generally speaking, I think that in the majority of the patients, these antibodies will work through a similar fashion, that is via NK cells and phagocytic cells. So I think that the nuances are probably related to a minor fraction of patients, perhaps those with very bright CD38 expression, whereas for the majority, they may work similarly, but we don't know for sure.
Elias?
So at that time, I totally agree with Bruno that from a clinical perspective, I would not expect daratumumab or isatuximab to be much different regarding the overall response and the PFS rate they produce in a certain treatment setting. So at that time, of course, we were able to get isatuximab in combination with RVD. And for us, if you think from a patient perspective, in 2016, 2017, VCD was the standard of care, 3 or 4 cycles. So at that time, to give patients RVD in Germany and even 6 cycles, so we already knew that 3 or 4 cycles were too short. There have been some old data from the United States, from Reda et al., that already showed that the more you prolong induction, and I think also Marivi has shown some important data on that regarding VTD, the deeper the responses go. So we thought 6 cycles would be kind of perfect. And as you may know, in the HD7 trial, we omit consolidation. We don't do a consolidation because we weren't sure if that's too much. But for now, I think 6 3-week cycles of RVD is balancing very well. On the one hand, what the patients may need and can do. I think that is some issue with the Spanish study, that I think half a year of induction is very, very long. 18 weeks is a bit shorter. We don't know what's best, but it's also more dose dense in our trial compared to the Spanish study. So I think the effect is very rapid. And at that time, giving RVD to patients in Germany and 6 cycles, it was like, wow, even if you're in the control arm, you're in a very good situation compared to what you can get in Germany, because you could not get any consolidation. So the best thing you could get was 4 cycles VCD, transplant, and maintenance in 2017 then.
So definitely we will need a full debate about this issue of number of cycles and consolidation, because maybe at the end of the day, it's about giving everything before transplant or splitting it between, before or after transplant. But I will not go in this direction because I don't think that was the goal of the paper. Here, my question to you, Bruno, because we want to be a little bit, so you said all your nice words. Now we want to be a little bit critical. And for me, I would like to hear your opinion about the MRD technique used in the paper, but also the alternative, but also the threshold that we should target because I guess CMW is recommending 10-5. I'm personally a believer of 10-6. You have flow cytometry. Elias has been very positive on the feasibility across 67 different centers. Some people claim it's easier to have something with NGS, and then you can get a deeper threshold. What are your thoughts on the methods here? And if you have to do the same trial, would you have done things differently?
Probably not. And I can tell you that we are starting now a new trial in Spain with a complex study design. Will not steal any of precious time on that. But again, investigating 3 versus 4 drug, different duration of treatment, and we are using the same exact method. But as Elias pointed out, it's 2022, and they designed the study in 2016, 2017. And when I said before that the authors were very brave, they were brave because of the primary endpoint, but also by the selection of the method, because the experimental arm included an anti-CD38 that we were back then trying to mitigate, because obviously we are blocking one of the antigens that is typically studied while performing MRD assessment using flow cytometry. So I think that again, this was very important. It was brave, and I hope and I'm confident that the method worked properly in all patients, regardless of the randomization. Now, I think this also illustrates the challenges we face as cooperative groups in designing large clinical trials. And this was a 660 patient clinical trial, because roughly the cost of MRD assessment, let's say 3-4 time points in this large patient population, may nearly be €1 million using flow. If you use alternative methods that are more expensive, well, it's about multiplying it for 2, 3, or 4, or even 4. These are very expensive numbers for cooperative groups, even with the support of the pharmaceutical companies. And therefore, the cost of the method is an issue to have into consideration. I think that providing in such an important study, a phase 3 study comparing a standard versus a 4-drug regimen, choosing one or the other method endorsed by the International Myeloma Working Group is mandatory, and the German group selected flow as one of the 2. And I think that is fine, as it would have been fine selecting sequencing. As Elias mentioned, with flow, you can bypass the baseline sample, even though I'm sure this was tested, also because of cytogenetics and other research questions. And regarding the sensitivity, I should emphasize that the guidelines, the 2016 guidelines, they say, and I hope I'm not wrong, that you need to achieve a minimum sensitivity of 10 to the minus 5. It's not saying that 10 to the minus 5 is the optimal threshold. This being said, I agree with you, Mohammed, that from a prognostic point of view, and even if you are measuring it in the routine practice, -6 may be the most informative cutoff, because we know that if MRD in that level persists, that translates into inferior PFS, and your group has nicely shown that in the IFM 2009 study. However, in the clinical trial setting, in the primary endpoint, I think that the -5 threshold is reasonable. And the reason why I say this is because you want to ensure that you are measuring in all patients in the ITT with the same sensitivity. And I'm confident that our German colleagues reached -5 in the vast majority, if not all patients. Certainly -6 in many, but -5 in all. And I think this is important when your primary endpoint is the rate of MRD negativity.
Thank you.
If I can add two more sides on that, because I think Bruno already pointed out that the costs, and I think the costs are becoming in healthcare, even in our developed countries, are really becoming an issue. And I think, Bruno, if we talk about an established flow cytometry MRD measurement compared to an NGS measurement, I think we talk maybe about 5 to 7 times higher costs even. So, and if you consider this, this would mean that the patient can get 2 cycles of RVD just for one measurement. And we are struggling now when looking at NGS and the very high costs. And another thing which I have to add is the time you wait for the NGS results. If you don't pay additional money to the company that has the approved technique, you even get into a situation that you wait for it for months. And this is, I think, if we think about the next steps, how we want to design clinical trials, and we already do that, we want to do an MRD tailored treatment. We cannot say, okay, if I don't spend more than $5,000 or $6,000 for a single measurement, I need to wait for 2 or 3 months, then I cannot make an MRD guided decision compared to flow, where I can do it. And as you said, it was easy for us to reach the 10 to the -5 threshold. And
so, Elias, my role here is to moderate and to be fair and balanced, because I believe cost is always an issue. However, I personally believe that the patient deserves the best, and curing multiple myeloma, it depends, you know, what is the value of cure and how you quantify the cost of life, because we have a good example from the last couple of years with the COVID pandemic, where suddenly we found billions just to compensate, you know, the closing of the bars and restaurants. But I will not enter into this political debate. My other role is to be fair about the NGS, which is a great technology.
Which is a great technique.
And it doesn't cost the price that you mentioned. I know what is the price, and the results can be achieved very quickly in a few days, especially that you can have central lab. Not everything needs to go to the US, but that's another debate. Let me here ask a question. We have because of course we need also to debate with our audience, guys. We have Dr. Sarah Reynolds, which is raising the issue whether focusing on MRD achievement at time of induction is really the right thing. And in another word, would it be interesting just actually to achieve MRD negativity at some time point, and actually, as long as you can achieve MRD negativity as part of the treatment package, it's okay. Why should you test it very early? Or maybe you should test it at different time points, because here we have a single time point. Bruno, what are your thoughts on this?
I hope I understood the question correctly. What is the most relevant time point for the MRD negative definition, and if as early as after induction before transplant is the optimal time point? From a clinical prognostic point of view, obviously, the latest readout, the more informative it will be. And we know that the MRD status is highly dynamic. High-dose melphalan will obviously have an impact on that status, as well as maintenance. And maintenance is the other part of this study. However, for the purpose of the part 1 of the clinical trial, that was the investigation of a 4-drug regimen versus the standard 3-drug regimen, I think that attaching the MRD assessment right at the end of induction is the correct decision. And in fact, picking up on one of the comments from Elias a few minutes ago, one of the hurdles we may be facing while trying to establish MRD as a surrogate endpoint with the previous data we have available is often the gap in between MRD assessment and what was being randomized. Because as you add other blocks of treatment, that will change the readout. So I think that if you are comparing 2 different induction arms, right at the end of the induction is the optimal time point for the MRD assessment, thinking on surrogacy only, not prognostication.
Excellent. So that brings me, Elias, to another issue, which is about, and I have shown in my introduction the different subgroup analysis. And we have a few questions from the audience, for instance. whether based on what you already know, there are patients where triplets are sufficient for induction, or you would use quadruplet inductions, like in this case, isatuximab VRD. Also, I think isatuximab plus VRD is not approved yet for induction.
Yeah.
By the way, daratumumab VRD is not yet approved for induction. The only approved is daratumumab plus VTD, although people are using frequently, I think, Dara VRD or isatuximab VRD these days based on these results. So any thoughts on whether it's universal quadruplet, or and I'm not talking about availability and cost. It's just from a scientific point of view.
No, so I think this is a very, very important question, because beyond the issue about the costs and everything, I would say as of now, the study was not designed to look at specific subgroups, right? So it was basically, what we did was a post hoc analysis. And there we could see that most of the subgroups appear to benefit from the addition of isatuximab. And that brings me to, I think, one of the new paradigms that we will tackle in the next years, and that will be that we need to define subgroups in the myeloma entity itself, because myeloma is not myeloma. It's many different diseases, and this can be defined by biological risk, like at the beginning, but also via the MRD status. And what we saw basically is that most subgroups had a benefit from isatuximab. Of course, it was not significant, especially in the small subgroups like the revised ISS stage 3, where we only had very small numbers of patients. But we made a small subgroup analysis, which we presented at the EHA this year as a poster, and there we looked very specifically in the cytogenetic subgroups. And if you take the high-risk cytogenetic subgroup overall, including deletion 17p, translocation 414, and 1416, and gain 1q, 3 or more copies, you see a significant benefit with either RVD versus RVD. Again, this is a post-hoc analysis, but there we had a larger collective, and we also saw this trend in patients that had even more than one of these high-risk aberrations, which were considered ultra-high risk. So I think for now, I would go with a quadruplet for every patient that can do it. So
I think it's a wise and reasonable recommendation, and I think there is a consensus within the community to go towards a quadruplet based on anti-CD38 and the proteasome inhibitor IMiD and dexamethasone. The question for you here, Bruno, is while we're talking about MRD negativity, is here it was an endpoint, and one may wonder whether one can use MRD as an endpoint for a dynamic assessment of the risk of the disease. Because if you give your best induction like isatuximab VRD, and your patient is only in PR or VGPR or even MRD positive, like 50%, is this a tool you would envision to be used as a sort of a reassessing the risk?
Definitely. I think that reassessing the risk for sure, as we know that the depth of response can modify a high risk into almost a standard risk, and vice versa, by the way. So definitely risk being dynamic since diagnostic, initial staging, and depth of response. But I think that your question leads to the other part, that is, if a patient is resistant in terms of residual disease after your best 4-drug regimen, is it reasonable to continue treatment using the same half or one of those drugs, knowing that the chances for the depth of response to improve thereafter are scarce? And that is perhaps what is being investigated in some clinical trials that are soon to be initiated or are already ongoing. Obviously, this is a very important question for which the only valid endpoint would probably be OS, and then we have to travel a very long readout, because changing drugs, almost having like a second line of therapy, can probably reinstate an MRD or induce an MRD negative status. But if doing that now or waiting until biochemical or clinical relapse, does that influence the patient overall survival? And I think this is a very important question that, unfortunately, and this is my opinion, by now we don't have the data to fully address, to fully answer.
Thank you very much, Bruno, for a very clear answer. One question to you, Elias, from a colleague, is about stem cell mobilization. And I think it's a fair and reasonable question, because we know that mature progenitor hematopoietic cells do express CD38, not, I think, the most immature stem cells, which are CD38 negative. So did you encounter or did you face any difficult issue with stem cell mobilization when using isatuximab VRd for induction?
Yeah, I think this is a very important question, and we analyzed this also in a part of the paper. And what we saw is that 1/3 of the patients roughly needs a rescue stem cell mobilization after the 6 cycles of isatuximab RVD. So yes, we know that this is an issue. Unfortunately, in our trial, we did not capture very detailed data, whether this means that the patient needed a second mobilization that was chemotherapy-based, or a second mobilization using plerixafor, or if plerixafor was just added. Because in Germany, the initial way we harvest stem cells is that we give a cyclophosphamide-based regimen followed by GCSF, and then we collect stem cells. And we already call it a rescue mobilization if we need to add plerixafor at that time. However, even if this difference is obvious after this 6 cycles with a long induction, we saw no decreased number of patients that had a successful harvest of stem cells. And a successful harvest of stem cells was defined as having at least 1 transplant with 2 million CD34 positive cells per kilogram body weight. And we did not see a lower number of patients going into transplant. So basically, but this is just a random observation, is that we saw that even more patients with the ISA RVD overall went into transplant. And the reasons for that are manifold, but stem cell mobilization, though we needed more rescue mobilization, was not impaired overall. Yeah.
No, I think these are good news, and I think we can confirm that now the accumulating experience with quadruplet is showing that maybe you have less stem cells in terms of numbers, but you have enough cells to perform your transplant. Bruno, we have a question from Dr. George Shen about the different techniques one would use to measure disease. So you are the king of MRD, but obviously patients don't always love to go through a bone marrow aspirate and do MRD, whether NGS or flow. And the question is about circulating tumor cells, but also mass spec. Where do we stand in this field today?
Thank you for the question. I think it is a very important one. Let me elaborate a little bit more by emphasizing a point in the study design that I think it is important. And it is the fact that MRD was assessed regardless of the response category the patient was in, so beyond CR. And this may be seen as controversial, but I should say that in my opinion, it was a very good decision from the group, because it is our experience that if you do not establish an MRD assessment at a specific time point, regardless of depth of response, you start having a lot of missing data. And the authors shown very scarce missing data. That is tremendously important, being MRD the primary endpoint. So I think it is reasonable for having MRD assessed regardless of depth of response. Well, if a bone marrow aspirate is needed for MRD assessment, another very good reason to use the methods endorsed by the International Myeloma Working Group to make the best out of that bone marrow aspirate. And those are NGS and NGF. And on top of that, we know that PET-CT is complementary. Now, how to move away from a few bone marrow aspirates into peripheral blood? Because I think that the marrow will always be there, as we see it in acute leukemias, but perhaps we can find a scenario where we can complement marrow and blood and decrease the number of bone marrow aspirates, particularly as patients' PFS is becoming longer and longer, and MRD continues to be assessed throughout maintenance and even observation in some studies. Now, we are presenting data at ASH. We, at the CTC level, using flow, but also other groups using mass spectrometry, measuring the M protein in the serum, also high sensitive NGS, using a similar approach as we did for flow. And I believe in two things. The first is that it is possible to increase 1 log the sensitivity of NGS and NGF in blood, not in the marrow, in blood. And I believe that enhanced next generation MRD plus mass spectrometry will be an alternative in blood compared to current methods measuring MRD in the marrow at late stages of treatment. I think that at induction, after intensification, we may continue to need the marrow, but eventually during maintenance or observation, if maintenance is not until disease progression, we may replace, if not all, many bone marrow aspirates by frequent peripheral blood testing. And I think this is important.
Thank you, Bruno. And I think the future looks really bright. So my last question of this journal club is to you, Elias. Remember, my first question was to Bruno. Last question is going to be for you, is about what's next. And why I'm asking this, because we received a lot of comments and questions saying, well, okay, how can we do better with bispecific antibodies? How can you do better with CAR T cells as part of this full treatment transplant package? So if you have to run now the next generation trial using this trial as a background, it's already an excellent one. It's isatuximab BRD, 50% MRD after induction. This is the highest rate I've ever seen in this setting. What are your vision? What are your views on how to go beyond? Would you combine isatuximab with a bispecific? Would you get rid of something? What are your thoughts?
Yeah, I think this is a great question to answer, because it really gives me the opportunity to outline some visions I have. And I think these visions are shared between our groups, so between the Spanish group and of course the IFM. And one vision is that we still don't have to read out if it's worth to add a CD38 antibody to IMiD-based maintenance. So HD7 and also the Perseus study will give us some more information, but there already the situation becomes to get difficult, because what I know from our HD7 trial is that patients experience far less events than we expected when we started the trial, which is excellent for our patients, and I'm very happy about that. But it leads to the situation, and it's the same in Spain, in the US, in France, that we need to wait longer for the readouts. So based on that, I think another important vision for me would be that I think we should go for MRD tailored treatment, and that we should really think, if patients have sustained MRD negativity, as shown in the master trial, that it should be an option to allow patients to go off treatment. And I think this leads to a vision I have, that I think our treatment, if it's becoming that good, and if we can give it to the patients, we should also begin to look at the patient's quality of life and see if there are good reasons to stop treatment from a biological or treatment perspective, and to give patients really treatment-free intervals or treatment-free time. And I'm sure that the bispecific and the CAR T cells will give more and more patients these opportunities. And I think maybe 10 years from now, autologous stem cell transplant will still be an option, but maybe not the first option if we have CAR T cells or bispecifics. And the second vision, I already mentioned that a bit earlier in our talk, is that I think myeloma is not one entity, and that Bellini is a very good example. The Bellini trial is a very good example how we can look into specific subgroups and really use the broad variety of agents that are given to us by the pharmaceutical companies to really specifically focus on patient subgroups. And I think this will be the next steps, the next two steps, that we see do an MRD guided treatment and really look more specifically in all the myeloma entities, because we all know here in the audience that myeloma is not one disease. We will see even in our RVD arm, for example, we will see patients that achieve MRD negativity and will be alive without progression after 10 years. And these patients, they would never have needed an anti-CD38 antibody. So it's really an important question, I think.
Well,
I want to thank you.
Well, thank you very much. This has been really a lovely discussion, and we could continue like this, I think, for the rest of the night. But the good news, guys, is that in a couple of days, some of you will be heading to ASH, and then you will be able to deepen and to learn more about everything that was mentioned. Obviously, if you want to hear more about the isatuximab-based combinations, I think at ASH we have an update about the concept trial in high-risk disease with isatuximab KRD. Bispecifics, there are abstracts about talquetamab, 2 abstracts, oral elranatamab, the phase 1, the magnetism 3, the Majestic trial, teclistamab, daratumumab, the Regeneron 6234, the alunectamab, and last but not least, cevostamab. I would like also to remind you about a new class of drugs that will be presented at ASH, because we're talking about immune therapy, modakafusp. So we need to learn how to pronounce all this. So see, it's a very, very exciting program. So thank you again, Bruno. Thank you, Elias. Thanks to all the colleagues who participated. I do apologize, we were not able to take all the questions because, and some questions would have taken us beyond the I would say, scope of this journal club, but I'm sure you can reach out to Bruno or to Elias by email, and they will be more than happy to answer. So, well, if you're traveling to ASH in a couple of days, I wish you a safe trip and hope to catch up together. If you're not traveling, well, don't worry, guys, because the IACH is organizing next Tuesday on the 13th of December at noon New Orleans time, which is 7 p.m. Paris, Salamanca, Heidelberg time, a take-home message from ASH. It will be a live broadcast, the take-home message in leukemia, lymphoma, myeloma, transplant, and we have already a nice dozen of top experts who will lively give you their take-home message before boarding their flights back home. So please stay tuned, and I think wherever you are, please stay safe and keep well. See you soon. Take care.